Hello everyone, myself Dr. Bhavik Champaneri. Today I am going to talk about cyanotic spell, its mechanism and its management that includes medical as well as transcatheter management. What is cyanotic spell? So it's also called hypercyanotic spell and it's an pediatric emergency which requires prompt recognition and intervention to prevent disabling cerebrovascular insults as well as it is important to save lives. How to recognize spells? Commonly it's seen below 2 years of age. Often it peaks between 2 months to 6 months of age, spontaneous and unpredictable, more often in early morning, although it can occur any time in the day. Infant cries incessantly, child is irritable and often inconsolable. Tachypnea is a prominent and cardinal feature. Typically these infants have a pattern of deep and rapid breathing without significant subcostal retractions. That is called acidotic breathing. Cyanosis deepens as spell progresses. Later, gasping respiration and apnea ensues, which leads to limpness and ultimately it can end up with anoxic seizures. It can last from minutes to hours. Auscultation often reveals there is a softening or disappearance of murmur, which is a pulmonary ejection murmur. Occasionally, patient can have profound bradycardia as well. What are the lesions which produce the spell? So there are I would say any VSD with pulmonary stenosis physiology, that can include tetralogy of Fallot with pulmonary atresia, tricuspid atresia with pulmonary stenosis, double outlet right ventricle with VSD and pulmonary stenosis, DTGA or corrected TGA with VSD and pulmonary stenosis, single ventricle with pulmonary stenosis physiology, atrioventricular canal defect with pulmonary stenosis physiology. What are various mechanisms? As we talk about mechanisms, often we should learn about having there is always a balance between pulmonary vascular resistance and systemic vascular resistance. So whenever there is a change or suddenly decrease in systemic vascular resistance, it always precipitates the development of cyanotic spells, and there are various theories which have been suggested for that. So often at any point of time when there is reduction in systemic vascular resistance because of any issue or any insult, it will result in significant right to left shunting across ventricular septal defect, which will give rise to severe cyanosis, which will end up in stimulating the chemical receptors which will induce hyperapnea, and it will induce the vicious cycle which will end up with in cyanotic spells. There are various theories suggested for cyanotic spell. One is Wood's theory, which is second one is catecholamine release theory, which states that there is a increase in catecholamine release, which leads to increased myocardial contractility and infundibular stenosis. Another theory suggests there is episodes of paroxysmal hyperapnea, which gives rise to the effect of cyanotic spell. Hyperapnea increases the systemic venous return, leading to right to left shunt as well as oxygen consumption through increase in work of breathing. Dr. Kothari's theory states that there are special mechanoreceptors in right ventricle which gives rise to the stimulation of these mechanoreceptors, which will give rise to the increase in infundibular spasms, and it will end up with development of cyanotic spells. So these are the various theories. Another theory states that there is a predominant involvement of infundibular involvement, and infundibular spasm will give rise to sudden increase in RV outflow tract obstruction, which will end up in increased right to left shunt across ventricular septal defect, which will give rise to cyanosis and further development of vicious cycle of cyanotic spell. So this cycle, you can see there is increase in cardiac rate, which gives rise to increase in cardiac output, which will end up with increased venous return, which in the presence of fixed RVO2 obstruction with increased right to left shunt across the VSD. There is systemic desaturation, partial oxygenation, and pH reduces, carbon dioxide level increases, which leads to hyperapnea, further giving rise to increase in cardiac rate. So that's the vicious cycle of cyanotic spell, and we have to break this cyanotic spell by breaking this cycle. Coming to medical management. So medical management, I'll explain you all by giving an example of a case which come across frequently to our ICU. So case details, it's a 3-month-old male child who presented to casualty at early morning in 7 a.m. with complaints of excessive crying, significant bluish discoloration of body and fast breathing. There was no history of fever, vomiting or diarrhea. On clinical examination, patient is very irritable, his weight is 4 kg, he is having severe cyanosis, SpO2 of 60%, tachypnea with respiratory rate of around 50 per minute. Heart rate is 160 per minute. On examination, S1 is normal, S2 is single and there is a faint ejection systolic murmur over left second intercostal space. So what we are dealing? So it's obvious, it's a patient who has presented with cyanotic spell. So how should we manage? So first we take emergency IV access to secure the circulatory parameter. We give a normal saline bolus 10 ml per kg state. We give oxygen with mask at 5 liters per minute. Child is placed in knee chest position. So that's an example or a picture of knee chest position where child's knee is pressed against the abdomen and this position is maintained for a while till cyanotic spell subsides. So how fluid bolus helps? So basically it increases the preload to RV, which will give rise to increase, and this RV volume will increase, which will reduce the infundibular spasm and it will give rise to increase in pulmonary blood flow. Then what is the mechanism of knee chest position? So what happens, this is inferior vena cava, this is a picture of aorta. When we do knee chest position, we are applying compression at this level. This line suggests, this line shows the level of compression of IVC as well as aorta by knee chest position, and this compression of aorta and femoral arteries or common iliac arteries will give rise to increase in systemic vascular resistance. As you can see here, increase in SVR will lead to increase in blood pressure, which will reduce your right to left shunt across the ventricular septal defect. Coming to next, since there is a compression of IVC at the level at the level of common iliac vein joining, this will give rise to reduction in systemic venous return. Because systemic venous return is reduced, more deoxygenated blood reaching to the heart reduces, and that will give rise to reduced stimulation of respiratory centers, and it may help in breaking the vicious cycle of cyanotic spell. What are other positions which mimics knee chest position? So this is another position which is in newborns, where baby is held over the mother's chest and with knees bent, and it will mimic a knee chest position. This is called a squatting. So basically squatting is also an adaptation of older children to avoid or to delay or to terminate the development of cyanotic spells. So these are the two positions which mimics knee chest position. Further course of this child, we gave injection morphine 0.1 milligram per kg, which was given over 1 minute. So what is mechanism of morphine? So basically morphine is analgesic, it gives sedation, it reduces your sympathetic stimulation and catecholamine release. What are the alternatives to morphine? We can give ketamine, that in the dose of 1 milligram per kg, and it has a dual benefit. It gives sedation, in addition it increases your systemic vascular resistance, so that your right to left shunt across ventricular septal defect reduces. Coming to next, patient continued to have spells despite giving a knee chest position, IV fluids, morphine. Patient continued to have spells. So what is next step of management? We are giving another bolus of normal saline at the dose of 10 ml per kg. Again we started on beta blocker, that's a metoprolol. We gave 0.1 milligram per kg of metoprolol IV over 10 minutes. So, and after 10 minutes another dose of metoprolol was given at the same dose of 0.1 milligram per kg. So basically, now what is the role of beta blocker? How beta blocker affects or terminates the cyanotic spell? So basically it reduces the heart rate. As we had seen in the vicious cycle of cyanotic spell, the increase in heart rate is a predominant factor giving rise to development of cyanotic spell. So it reduces the heart rate, it reduces infundibular spasm, it has a definite some reduction in sympathetic stimulation and catecholamine release. What are the alternatives to metoprolol? We can give propranolol if it is available in the dose of 0.1 milligram per kg and in the same duration of around 10 minutes, or we can give esmolol at the dose of 0.5 milligram per kg IV bolus over 1 minute. Now we took ABG of this patient, and on ABG findings, patient was having severe acidosis with a bicarb of -10, HB of 10, hematocrit of 32. So what is the important finding here? Here you can see the bicarb is on a bicarb is low and hemoglobin is on the lower side. So what we are doing now? Now we can on based on this ABG finding, what is your probable precipitating factor in this case? So you can see it's anemia. What anemia will give rise to? Reduced oxygen carrying capacity. What are other precipitating factors? It can be infection, it can be fever, it can be diarrhea, it can be vomiting. Infection and fever will the mechanism of development, how it precipitates cyanotic spell. Infection and fever will reduce your systemic vascular resistance, and that's how it will start the vicious cycle of cyanotic spell. Diarrhea and vomiting will give rise to reduced volume or hypovolemia, which will further give rise to reduction in RV volume and aggressive infundibular spasm, infundibular stenosis, giving rise to further right to left shunting across ventricular septal defect and development of cyanotic spell. So we gave bicarb at the dose of 2 milliequivalent per kg IV over 30 minutes, and PEG cell transfusion was given at the dose of 50 ml per kg IV over 4 hours. So with this, child improved over a period of time. His SpO2 improved to 85%, heart rate improved to 130 per minute, respiratory rate came down to 30 per minute, and that is what is important. Child's ejection systolic murmur improved from a grade 1 or grade 2, it became grade 3/6 over left second intercostal space. That indicates that the flow across pulmonary artery or MPA has improved. So what are other medications we can give? Suppose there was termination of spell did not happen with this medication. What are other medications we can give? Then next medication is phenylephrine. So what's the phenylephrine is a basically potent vasoconstrictor. It increases your systemic vascular resistance, and it's given in the dose of 0.01 milligram per kg IV over 2 to 3 minutes. It's a life-saving drug in cases of cyanotic spell, and this phenylephrine should be available in all ICUs who are having a cardiac patients. It can be given in infusion at 2 to 5 microgram per kg per minute as well. Then next step comes is intubation and ventilation, giving general anesthesia, and that's how we can terminate the cyanotic spell. Further about this patient, our case, echo was diagnosed to have tetralogy of Fallot, severe infundibular PS. There was a large VSD and good size branch PS. So child was started on iron drops. Child was given tablet propranolol at the dose of 1 milligram per kg 3 times a day, and patient was discharged on second day of admission since patient was stable with the saturation of 85%. On follow-up, he underwent complete intracardiac repair at the age of 6 months. Patient's post-op period was uneventful. So first, what's important is iron deficiency anemia in cyanotic CHD. So it's very common, although we can see a patient with cyanotic CHD have higher hemoglobin, but that does not mean they are fully loaded with iron. And studies say 20 to 30% of patients with cyanotic patients have iron deficiency anemia despite having higher hemoglobin. What is mechanism of iron deficiency anemia and how it precipitates cyanotic spell? That's by hypoxia induces the erythrocytosis. Because of erythrocytosis, there is increased iron demand, and because the demand of iron is increased, it will lead to iron deficiency anemia, and that's why iron is an important drug to be given in all patients with cyanotic CHD despite their hemoglobin is on a higher side. Effects of iron deficiency anemia on cyanotic CHD is it reduces the oxygen carrying capacity, and that's how it increases the risk of spells. Again, because iron deficiency anemia, rouleau formation is more, chance of thrombosis is more, neurological event is also on a higher side in patients with iron deficiency anemia in case of cyanotic congenital heart disease. So what are the key points, learning key points from the medical management of this patient? It's important that cyanotic spells management should be segmental, stepwise, systematic. If you do a stepwise management of cyanotic spell, you can terminate very easily. Precipitating factors should be identified very vigorously, because those precipitating factors, if it's treated well, cyanotic spell can be terminated earlier and patient can be managed well. And iron supplementation is must in patients with cyanotic CH3, because it predisposes those patients to cyanotic spell as well as neurological events. So coming to transcatheter management of cyanotic spell. So why I am covering this topic in medical management? Because transcatheter management is being done by a cardiologist, and I felt like we should cover this transcatheter management in the management of cyanotic spell as well. So if we are having a child with cyanotic spell, we are trying to do a medical management, and if we are able to do medical management and cyanotic spell subsides, nothing is better than that. Suppose it improves, child is well, then what we will do, we will consider this child for early corrective repair. Suppose there is no improvement of cyanotic spell despite doing all the measures of cyanotic spells, or patient is having frequent cyanotic spells which requires frequent medical management, then we can consider for either emergency corrective repair. If it is feasible, then corrective repair is ideal. Suppose it's not feasible, then what to do? If it is not suitable for immediate repair because of some other reasons, then we can consider a palliative procedure. So what are the palliative procedures? Palliative procedures aim is to improve the antegrade flow across pulmonary blood flow so that you can maintain adequate oxygenation. So, and that's how you can avoid the development of cyanotic spell. So how can you improve pulmonary blood flow? You can improve pulmonary blood flow by doing balloon pulmonary valvotomy or RVOT stenting. What is another aim of palliative procedure? You can provide alternative source of pulmonary blood flow. Suppose you are not having enough antegrade blood flow, you provide alternative flow which increases your pulmonary blood flow, and that we can do by doing a PDA stenting or a BT shunt. So BT shunt is a surgical solution to that. Above 3 are a transcatheter solution for the management of cyanotic spell for doing a palliation who are not suitable for corrective surgery. So indication of palliative surgery, which are the indications? So usually, ideally, this data says 6 months to 2 years is ideal age for tetralogy of Fallot, although nowadays at younger and younger age we have started doing intracardiac repair and corrective surgery in selected patients. So what are the indications for palliative surgeries or palliative transcatheter procedures? Is young age of the child. If the child's weight is very low and surgeon is not comfortable doing intracardiac repair and he wants to do palliative surgery, or some other unfavorable surgical anatomy like atrioventricular canal defect or some complex DORV where the corrective surgery is not an easy solution, or the child is associated with significant comorbidities like very syndromic child, or some other reasons like cleft palate, cleft lip, or some sort of intestinal problems who can be comorbidities for the corrective repair, or some logistic issues like financial issues. So this can be an indication for palliative surgeries in patients who are presenting with cyanotic spells. So what are the options? It can be the palliation can be either surgical palliation. Surgical palliation can be in the form of BT shunt or Cyano shunt, where they put a shunt between the right ventricle and pulmonary artery, or it can be a transcatheter palliation. So I will be talking about transcatheter palliation. So first, for deciding on transcatheter palliation or the type of transcatheter palliation, you should have a detailed echocardiographic evaluation of the patient. Whether to find is there a predominant valvular PS. Always TOF has an infundibular PS, but there can be few candidates where there is a valvular component is significant, which you can make out by echocardiography. If so, if you feel the valvular component is significant, by just doing balloon pulmonary valvotomy, you can increase the pulmonary blood flow and you can improve child saturation and you can avoid development of frequent cyanotic spells. Is there a PDA? If there is PDA, we can consider for PDA stenting in these patients. Suppose this patient is having a multi-level outflow tract obstruction who is not suitable for BPV. he is not having PDA as well. So in those cases we can consider such patients for RVOT stenting as well. So I'll give you examples, different examples for transcatheter palliation. So this is a first case. He is a 6-month-old female child. Child's weight is 4.7 kilo, syndromic with significant development delay. She presented to casualty with severe cyanosis. He is having history of spells. On examination, she is having SpO2 of 45, syndromic child, heart rate is 130, respiratory rate is 24, very faint ejection systolic murmur with single second heart sound. On echocardiography, she is detected to have tetralogy of Fallot with AV canal defect, that's called a TET canal. So what are the factors which are not favoring corrective surgery in this patient? So that's a complex heart anatomy, because it's not just routine tetralogy of Fallot, she is having AV canal defect in addition to that. She is a syndromic child with significant developmental delay. So now on echo evaluation, she was detected that she is having a significant valvular component in addition to subvalvular component. So we have decided now to palliate this child because she is having a significant valvular component with balloon pulmonary valvotomy. So this is a diagrammatic picture showing a subvalvular component and significant valvular component of pulmonary stenosis. So what we do, from a femoral vein, we go and park the wire in branch pulmonary artery. We take the balloon and we do balloon pulmonary valvotomy, and that's how we increase the flow across the pulmonary artery, and increases the there will be increase in saturation, giving rise to termination of cyanotic spell. This is a cath image showing a balloon pulmonary valvotomy being done in a patient with tetralogy of Fallot, where you can have a good result and child improves after BPV and can undergo corrective surgery at ideal time. So child underwent balloon pulmonary valvotomy under IV sedation, saturation improved to 90%, child discharged next day on iron drops and propranolol. Currently child is having 1 year of age, she is awaiting corrective surgery, and SpO2, current SpO2 is around 80% of at 1 year of age. This is a second case. She is a 3-month-old female child who is weighing 3.4 kilo, presented to OPD with complaints of repeated episodes of cyanotic spell. She is a case of tetralogy of Fallot with central cyanosis, SpO2 of 70%. Again, now in this patient, what are the reasons for palliation? She is a young girl, 3 months of age, weight is 3.7 kilo, and branch PAs are smallies on echo evaluation. So now this is a diagrammatic picture where there is a significant subvalvular component, as you can see. So in this patient, if we do BPV, we may not get very good result because there is a significant subvalvular component as well. But what is important, we are having an additional PDA which is patent in this patient, and that can be an extra source of pulmonary blood flow. So we have decided to do PDA stenting, and this patient was having multi-level obstruction, so he cannot be a case for balloon pulmonary valvotomy as well. So, but this patient was having PDA, we decided for PDA stenting. So what we do in PDA, we go either from artery or venous side, we park the wire across the PDA into the pulmonary artery, we take the stenting and put a stent across the PDA, and that's how PDA stenting is done, which will increase the flow across from aorta into the pulmonary artery, and there will be the cyanosis will decrease, patient may be will be benefited, and we can buy some time by doing this palliation. So this is a picture showing procedure being performed for a patient with tetralogy of Fallot. PDA stenting is being done. This is an image where angio is showing a very tiny PDA with minimal flow, and stent is being deployed. Post stenting, as you can see here, you must see the pre-stenting video, which will show you very reduced flow, and branch PAs are hardly filling. In this, see, the branch PAs are not filling very well. Now see the next picture, see how beautifully branch PAs are being filled. So this is how PDA stent helps, it increases the saturation, and you can buy some time by doing this palliation. So this is a pre-procedure picture, this is a post-procedure picture showing increased flow and very nicely filled branch PAs. SpO2 in this patient improved to 90%. Child is discharged after 4 days on aspirin, iron and propranolol. Child underwent corrective surgery at 8 months of age, and child has been doing well. This is a third case. The child is 3-year-old male child, resident of Nepal, presented to OPD with excessive bluish discoloration of body. See, he is having significant development delay and he is a digeorge phenotype with 22q deletion, suspicion of 22q11 deletion. Diagnosed case of tetralogy of Fallot, but child is having severe cyanosis with SpO2 of 58%. He was advised for early corrective repair, but what's the concern? He is having a financial concern. So what we decided that we should go ahead with a palliative procedure. So in this patient, in this anatomy, you can see the patient is having significant subvalvular PS, significant supravalvular PS as well. So this is not a candidate for balloon pulmonary valvotomy. There is no PDA. So we cannot consider this patient for PDA stenting as well. So we have left behind with the option of RVOT stenting. So in RVOT stenting, we are parking a wire through IVC and parking a wire into branch PA, and we are putting a stent across RVOT. That's how we open the RVOT. By this, we will increase the flow across RVOT into branch PS, and that's how we can buy some time by doing this palliation, and we can avoid further development of cyanotic spell. So this is an example of RVOT stenting where stent is being deployed across RVOT, and it improves the saturation and alleviates the symptoms of cyanotic spell. Same patient improved to 88% of saturation, was discharged on 3rd day with iron and propranolol. On 2-month follow-up has been completed. Patient saturation is remaining around 85% and child is doing well. Surgery is still awaited. Patient will undergo surgery after necessary financial arrangements has been done. Key points: patient corrective surgery is an eventual solution, but suppose corrective surgery is not possible, we can consider such patients for transcatheter palliation, which is feasible, and in selected patients we can do very well and we can buy some more time by doing transcatheter palliation. Aim of transcatheter palliation is just to increase the pulmonary blood flow and stabilize the child. It's not a corrective surgery. Child is going to need corrective surgery at later date, but to improve the general condition or to buy some time or to improve some logistic issues, we can buy some time by doing such palliations. Thank you.